Time now for this week's Health Matters. PA Lynn Szabo, Paul Critz from KFUG here with you as well. And Lynn, today I guess we're talking about, this is my first line of defense when it comes to healthcare, the ER.
Which, I'm sorry to hear that. It really should be your last line of defense.
Well, yes, but, you know, we live in a special place, and there's all kinds of other stresses and things. But so discussing emergency room, what? Etiquette? What are we discussing today?
Yeah, I'm calling it ER 101.
Okay.
So just stuff you should know about the ER that come from my direct experience with working both at Sutter Coast and Mad River, and having some connections with Joe's. Very kind of peripheral, but... things
with
you
what?
need to
Some
know.
connections with whom? With what?
Some connections with what's called Providence now, but and my heart is always St. Joe's.
Okay,
We just call it Joe's.
Joe's, I was going to
Yeah,
okay,
because, you know, we're cool.
Well, now you are cool too,
Yeah.
listener. You know, the ambulance driver, you could say, take me to Joe's.
That's right, but you can't. Okay. So an ER is defined, kind of interesting. There's a Wikipedia definition. So it's a medical treatment facility specializing in emergency medicine. That should have an underline under it, for acute care patients without an appointment. And it can be associated with a hospital like we have here at Sutter Coast, or it can, I don't think the ER in Curry is associated directly with a hospital.
It's just a standalone.
It's just a standalone medical center.
Wow.
Yeah, so that's kind of cool. And anybody can come in for any problem at any time. So 24/7 access. And because there's federal law that keeps them from turning you away, although they have their subtle ways to suggest, you know, maybe calling your doctor or maybe going to the acute care clinic at Del Norte Community Health Center on Saturday from 10 to 2.
And those options are presented, I would assume, in a best case scenario as like, this is best for your treatment, as opposed to get out of our way.
They're
Really?
kind of subliminal, like standing in front of a little poster on the wall.
Oh, really? That's
Yeah,
pretty subtle.
Super subtle, because they can't send somebody away. Okay, it's against federal law.
Gotcha. Okay.
So when people can come in at any time for any reason,
They do.
they do, and so what keeps the basics of I guess organization in that kind of potential chaos is called triage. Okay, and so triage is a brief assessment of patients, and they decide who needs the most rapid attention and who can safely sit in an emergency room. And usually it's a triage nurse who's kind of the traffic coordinator in that situation, but sometimes they can put providers in triage. That's called PIT. That's what PIT is.
Oh, wow. Okay.
Provider in triage.
Okay.
So they'll have like a PA there, or maybe an NP. It's mostly PAs, though, for some reason. And, you know, they can say, let me just write the script for your infected ingrown toenail. I'll just write you some antibiotics now and go back to your primary.
So they can actually, okay, so triage isn't just about triage can also include dealing with something if it's low key.
Yeah, it can, if they're really
it.
simple, straightforward, and don't require a lot of diagnostics.
So is triage, nurse or PA or however, is it just the job you have when you show up that day, or is it an actual specialty?
Both, actually.
Both, really? Okay.
Both, yeah. Here, it's the job you have when you show up.
Yeah.
I don't think there's any... They're probably in bigger cities. There's PAs and NPs who are specialized in emergency room and urgent care. Urgent care now is actually a specialty, so you can be a physician and, you know, like you decide to be a pulmonologist or an urgent care specialist.
That
or,
makes sense, sure.
You know, trauma surgeon or whatever, you know, and that can kind of define your path and you get that special certification.
Okay.
So, but not here. Here is a surprising number.
There's so many things you say that end with, but not here.
Yeah. Alas, big sigh. But there are a lot of people working in the ER who, are dedicated to the community, and we can get into that later. Okay.
Okay.
So sometimes triage is accompanied or is accomplished while the ambulance is en route. Okay, so there's radio communication between the EMTs, which I think is mostly what we have here, but hopefully some paramedics, all doing a great job though, and they can talk to the nurses and the doctors, while they got lights and sirens going in the background.
Never occurred to me there would be a difference between EMT and paramedic. I just always assume same thing.
No, actually,
Okay.
paramedics have a lot more training and they can do a lot more cool stuff.
Wow.
Yeah.
Well, like what? What can a paramedic do that an EMT can't do?
I think they can intubate.
Can they marry people in the ambulance? I'm sorry, that's a flippant question. No, but they can intubate. What else? I mean, I think
it's certain drugs, like
more involved.
Morphine.
Okay.
Okay. And I think both of them can give, for example, buprenorphine if somebody needs it.
Okay.
So-
That's it. I did not know that.
Yeah, it's kind of cool. So sometimes it's accomplished on the way to the hospital. So people who are unstable go directly to the back and get priority attention, which is what you would want if your grandma was one of them.
Yeah.
Okay. And everybody else goes to the waiting room. And the next part is, I thought, actually kind of interesting. So people should assume that while they're in the waiting room, they're kind of being watched by medical people. And so they don't just like put you in limbo and ignore you,
Right.
although it feels like that. So wait times in the average in the United States are 145 minutes.
Wait, okay, so let me do the math. What's that? It's
a little over 2 hours.
A little 2.5 hours. So something.
Yeah. In Oregon, 157 minutes. And in California, 164 minutes. So that's all super better than I thought it was, actually.
Yeah. I thought the horror story would be 7 hours or something. That's the
Well,
average.
everybody says that.
Yeah.
That might,
Yeah, well, yeah. For my waiting in the ER, it's like if you're well enough to bitch about how long you've been sitting there, then you're probably sitting there for a good reason.
And as we get to later, the wait is a super good thing.
Okay.
If they make you wait, that means you're not dying.
That's a reassuring. Okay, all right.
So even you might be in pain. Okay. I get that, but you're not like at death's door. So weirdly beneficial statistic that is good about rural ERs is that the waiting time is less.
Except here. No, wait. This doesn't apply in this instance, huh?
Right. So
I've never waited like hours.
It's in comparison to like a tertiary care medical center. Number one, I think there's a higher flow of patients. Number two, they have more cool things.
A higher flow of patients where?
Like in a city.
Sure.
Think UCSF.
Right.
So you wait in the waiting room longer at UCSF. There's bigger staff. There's a higher flow of patients, and there's probably more cool things diagnostically that you could do for somebody. So that just makes longer wait times. But again, if you're waiting, you're likely stable.
Yeah.
Okay.
Yeah, exactly.
Yeah.
I think I've been to the ER here maybe 2-3 times in the last 20 years, right?
Yeah.
And they all came bunched up within a few months because it was a kidney stone.
Yeah, I
but I never sat for more than honestly like a half an hour here at Sutter. But maybe that's because I was showing up and
in my personal experience, which is super limited, I went once by ambulance for an anaphylactic reaction, so I got priority attention. Ambulance does not equal priority attention.
no, just priority
Not being
driving.
able to breathe equals priority attention.
There you go.
Okay, and then I took my baby in once, and we only waited 20 minutes, but nothing was going on there. So
it's fun to at least step back and go, hey, here's something. We talk about the divide between urban and rural America and the resources available to people like us who live in rural America. And we're always on the short end of that. But it's nice that here we can at least say, at least we don't on average have to wait as long in our ERs. Take that, big cities.
yeah. But the underlying reasons might suck a little bit. But anyway.
Okay.
So ERs, we have to remember that ERs are designed to reduce mortality and morbidity. Okay, they're not. So what that means is they want to keep you from dying in the parking lot, and they want to keep you from getting close to dying. Okay. So actions that they can perform in the moment are designed to reduce that. It's not designed to reduce your problem with coughing at night.
So they're not specifically like focused on we're going to cure you or fix your underlying issue. No, we're going to save your life
or
right
even
now.
diagnose your underlying issue. So this is what we're getting into. So you might go to the ER, and I read ER records constantly, like maybe 10 a day or something. And oftentimes we end up with diagnoses like cough. Okay. We've ruled out pneumonia. We've ruled out pneumothorax. We've ruled out, congestive heart failure exacerbation, COPD exacerbation. And well, they have a cough. Maybe it's virus. Go home,
Go give it some
breathe
time.
humidified air, which is, I think, hilarious considering where we live. But,
Yeah, right.
Yeah.
Where can I find this air?
I know. You open the window. So they're commonly used for minor issues, mostly because of the ease of unstructured access to healthcare. And I think this is actually a Delnart kind of thing.
Yes. This is a poor America kind of thing, isn't it?
Yeah, but I don't really have the data on that. But what it feels like is there's a certain group of people that just don't have access to resources, and so they make their access, even if it's not working in the bigger picture, as long as it's working for them. And that's hard to fault them for, actually.
Or the people who because, by necessity, like it's not by necessity. Like my lack of going to the doctor is just because I'm a guy and, this is my age and it'll catch up to me. And I understand all of that.
Yeah.
But there are people like that you see like at the homeless walk-up clinic who, are living in the bushes in the rain out here and
they can't walk that far.
And
because their feet are messed up, and that's their problem.
And they have to wait until it becomes an issue that severely limits them, and then it's a trip to the ER. Yeah,
right, totally. Yeah. So that's one of the reasons Open Door is going to get this, what they call a van, but looks more like a bloodmobile, and they'll be driving it around for pop-up medical care.
Wow.
Stay tuned. Hasn't even been built yet.
Is there any kind of transport service that somebody could call? Like, I mean, because
besides the obvious, like cabs.
Yeah. Right. Besides is there an emergency sort of, and ambulances and things? But I'm just thinking, is there homeless people? They all have phones, right? Because everybody has phones nowadays. If in an emergency, is there a free transport service they could call and say, "Hey, I need a trip to the hospital"?
Other than an ambulance?
Yeah, there isn't here. Huh?
No, there really is.
That seems like that would be an interesting service to provide for any nonprofit out there interested in doing that.
I think actually the same thing that applies to cabs in general would happen, that you'd actually end up being in a line.
What do you mean?
Okay, so when you call a cab, it's not like they show up in 5 minutes.
Nope.
Like I'm ready to leave Walmart now and go home with my groceries.
Right.
It's like, okay, we'll be there in like an hour and a half.
Yeah.
And the cab drivers and Uber drivers and they don't really want to drive medically unstable people, so they're super reluctant to pick up
sure. But I'm not asking about them. It seems like our daily bread or Mission Possible or something. If there's somebody on call, somebody needs
I still think they would be focused on legal liability. Like, what if somebody codes in the van?
Yeah, good point.
Yeah. So that's where I see them backing away.
Okay. No, that makes sense. Bummer.
But there are people in that I have personal knowledge of in this community who go to the ER like multiple times a day. And I think it's driven by anxiety, maybe partially, maybe mental illness, maybe lack of resources. And, sometimes in the past, the doctors would give you a $5 if you look like you were down and out on your luck and they were trying to be good people. But, that means that people just come back again. So I've seen people when I was working at walk-in, and I could look and see all their ER visits on the electronic health record, who had like maybe in 6 months, 24 visits to the ER.
Wow.
So in relation, and I'm not trying to get snotty here, but my family of four has our combined ages are 189 years, and we've accessed healthcare in the ER twice.
Right.
That's 4 people. Twice, and I've already mentioned that.
And so what is that?
I think
what's that exemplify? What's that spell out for you?
It's
just
that I access care under a health insurance kind of model,
right?
Whereas somebody else might be accessing under no insurance and just not caring, which is super common, or Medi-Cal.
Right.
And I truly believe that somebody on Medi-Cal who's not very sophisticated about, the medical world may not realize that going to the ER costs thousands of dollars. And even for something that's really minor.
The trip to the ER, if you take an ambulance, can cost thousands of dollars.
Totally.
And that's the most surprising. I've been in the ambulance twice in my life. And
I pulled a nurse off a patient when the patient said, it was her third visit that day, and she'd taken the ambulance from Fort Dick because she didn't have gas money. Wow. And then the nurse went for her.
Now, I'm not saying that ambulances are reasonably priced at all, but that's that's an $1,800 like ride, right? Nowadays?
Yeah, and I would argue more importantly, maybe that kept my grandmother from getting timely care when she coded.
Yeah.
And, that didn't really happen. I'm making that up. But
yeah, that's the kind of issue.
There's effects on other people in the community that aren't really well thought out, I guess. So one thing that happens in the waiting room that people don't know is that their condition is being monitored over time. So that all-seeing triage nurse eye is scanning the waiting room to see if people look like their clinical situation is changing.
Okay.
And sometimes it's beneficial to monitor people over time. And that might be like 4 hours or 6 hours, something like that. And it's not like, that's really known to the patient. So I'm not advocating that you pull a dying swan, which is what we call term? People who try and impress us with the level of pain. I don't mean to
showing up with the stage makeup on, getting ready to.
Yeah, but this is a clinical eye. Okay,
right. So this is a trained professional.
They're gonna notice that if you're like writhing on the floor in supposed pain, and then you get up and go outside and hang out with your friend and smoke a cigarette, that might. There might be like some secondary gain.
You're not really committed to your role.
Right.
I did have one of my trips to the ER for the kidney stone fund that I went through. There was the younger doctor. We've talked about this. He was like a surfer guy from Humboldt.
Yeah,
he was really cool.
Who that is.
You know who that? Long hair.
Yeah.
Dreads
sometimes.
And I had no dreads that day. But yeah, he assessed me as saying, well, so no, you're pretty healthy. You're just like a dude, right? That was like my assessment. Yes, I am just a dude. But he was very cool and very competent. I'm not trying to say he wasn't. But he said he was describing somebody with a kidney stone. You can tell just by looking at them. And he used the term, and I think it was colicky.
Yeah, renal colic. Yeah.
And just he said the scenario he presented verbally to me was that you can walk into a room and look, and you could tell who has the kidney stone just because of the way they're moving and things like that. And I was just wondering if that was sort of like, is that an insight into some of the?
Yes, actually, there's studies that say that a well-trained healthcare provider can usually get a good idea about diagnosis within 7 minutes.
And just looking at you has a place to start.
But
right?
What? That's also dangerous because you can also be wrong.
Right, and you take a shortcut.
If you're only seeing one frame in the film, it's a little hard to extrapolate.
Right.
But was that the one who told you about the wonders of Toradol?
No, I asked the nurse because I got the Toradol in there, and all of a sudden I did not feel any pain. And it wasn't like I was stoned. I just all of a sudden the pain that had sent me to the hospital. I'm like, I'm just a dude again. And I felt like, wow. Yeah, I was amazed at Toradol. Okay, so sorry. Yes, so I like that. I don't know, that ability to walk into a room and being a professional and just kind of look around and go, okay, I know avenues of exploration, questions to ask, lines to follow, just looking at these people.
Sometimes I feel like I go in the room and I go, well, there's your problem. I'm the guy missing the finger pointing with the third finger. Anyway, you see patterns. When I was in the Castro, that I think I said recently on the air that it wasn't hard medicine because people died in like 1 in 10 ways, and you could see it coming really quick. Same thing with the emergency room. Yeah. And not necessarily death kind of stuff. But so the providers that work in the ER, this needs to be understood here. They're employed by a separate business than Sutter. And I think people learn this lesson. First of all, I don't think they were super upfront about it. I mean, I'm sure there's something posted in the stuff that you read on the walls while you're waiting. But people didn't really internalize it. But it's kind of like if you go into Walmart and you buy groceries and then you pay for them, and then you go into Subway and you buy lunch, you're actually buying lunch. That's another transaction because a separate business is within the parameter of the Walmart interior.
That's a good way to illustrate that. Think of Subway. How Subway is inside Walmart without being part of Walmart.
Right, in the coffee place and the little touristy place.
So what's the term for those companies that run ERs? Are they independent contractors? Are they just contracted with the hospital?
Yeah, they're usually independent contractors. A lot of doctors who kind of are like hired guns and bounce around in communities are independent. They're their own S corps.
Sure.
And having experienced being one until the Uber struggle made my S corp illegal. It's a pretty smart business decision. And so these guys, I think the only people allowed to have S corps now are doctors and lawyers and something other weird like dentists or something.
Okay.
And they don't really pay taxes up front. What they do is they funnel their income through a business and they get taxed at a lower rate. So there's it's a little seedy, but
it's not seedy. It's their ways to play the system.
It's something that they can do, and they do it.
But you're talking about the individual doctors, right? Who do their own escort
so they're
thing.
independent contractors hired by.
What I'm asking about is the company that will then run an ER, right?
Right.
So that contracts with the hospital as a separate entity, the way Subway would with Walmart.
Right. Exactly. That's it.
Is that more common now than an ER?
It is more common, and the smart business move, I'm putting air quotes on that they do is they just don't accept any insurance.
Wow.
And so that means you have to pay up front. You don't have any negotiated discount. You don't have any power to make a negotiated discount. And then maybe you can submit the bill to your insurance company and maybe get paid back for it.
That's not how it works here, though, right? I mean, here in Del Norte is what I'm saying, listener, with our one hospital.
Actually, for some people, it does.
Okay.
I don't know about Medi-Cal, though, or Medicare. Those might be immune to that.
I went in with somebody without any resources, and went through the whole thing, and got the bills, started coming in. Everybody who's in the room sends you a bill, and but before I started getting the bills, and I was finished with the treatment initially, and stent, and I'm waiting. Okay, great. Sutter was very good about setting me down. Sort of, I imagine it's analogous with like Open Door in their.
You were their new best friend in getting Medi-Cal.
They totally made it the easiest thing. I didn't have to pay a cent for that, but all that money went to them then.
Right, and you can get retroactive. So that happened with my daughter once, where she had an ER visit and then lost her insurance, and then was able to get retroactive.
Yeah, if they're setting you up for Medi-Cal so that they can get paid, the customer service is remarkably efficient.
It is since partnership showed up. So yay, partnership! Once again, making a plug for patient services in the Del Norte Community Health Center lobby. If you turn left instead of signing in with the receptionist to the right, those are a lot of people whose job is to get you health insurance. Yeah. And not just partnership, but, anything off the exchange. Yeah. Thank you, affordable health care. So it's a little weird that some providers get paid on the basis of what they order. And so it's easy to order x-rays and CT scans and labs and stuff when in your mind you're thinking, well, this is probably going to be okay. And where this comes in is that for a provider to order 100 CT scans of the abdomen, which I've probably done, you probably had a CT scan in diagnosing you. By ordering 100, I'm going to give on the average one person cancer. And so if I'm ordering them to pad my paycheck, that to me, I think is a little bit
evil.
Weird. Yeah, but you can talk yourself into it saying,
Well, the 99.
Clarify the diagnosis. I'm 99% sure, but I was wrong last Thursday, and that's not going to happen again. Oh. So there's a little bit of weirdness there. I was not very good at that.
And the whole, I mean, you talk about there's lots of rule out the lawsuit of CYA sort of medicine, but is that wrong? I mean, how prevalent, how much of a worry for a healthcare provider is being sued, is
it's
malpractice?
constant.
I mean, you get insurance for malpractice, right? Don't you?
Right.
Do you?
Well, I personally don't, but there's, like I'm insured by my employer right
Gotcha.
now. That's
Okay.
the federal government.
Right,
so.
right.
And in California, that you could argue that it's really hard to sue providers, and you don't really make it financially, feasible for lawyers to do that, because I think that the rewards are capped.
Are they? Okay, yeah, okay.
But I also have not very often, like virtually never seen somebody that I thought was so incompetent that they should have been sued for malpractice.
Have you seen doctors, healthcare providers who were sued without cause?
Absolutely.
Okay.
That's pretty common.
Wow, okay.
Yeah. And I've seen a lot of people there was yelling about suing that was really more just anger at a provider's attitude.
Right.
And so not really a critique of the medical care. And so it doesn't really go anywhere.
Yeah, yeah.
But I have seen, I saw actually a family practice PA in Arcadia that got sued by somebody who bought into have you or a loved one. And so he defended himself $8,000 for lawyers, and he had never prescribed the drug that the patient was suing.
Oh, my God.
Yeah.
Wow.
Yeah.
Yes, so you have to be able to make that sacrifice
Yeah.
to prove that you didn't do something wrong.
So the job of the ER is to make sure you don't die in the parking lot. I really want to say that. And their job is not to clarify what's causing your cough. So you might come out of there with no clear diagnosis, and they'll bounce you back to your primary care provider, which you have. If you are a partnership person, you might say, what? I don't have one. And you've been assigned. That person is getting money every month to take care of you. So figure out who they are.
Yeah.
Here's an insider tip. It's on the card that they sent you.
Oh, they send cards?
Yeah. Yeah. And often this is what slays me is the ER will make an appointment for the patient with the primary care provider. Let's say a lot of people maybe who are in the ER will bounce back to me, and they will have no idea they have that appointment.
Wow, really?
I don't know
okay.
how that works.
Okay.
Anyway.
It's a confusing thing. You got other things on your mind when you go to the ER.
Well,
And it is a very complex system, too. And a lot of people are throwing pieces of paper at you and saying things to you.
And it brings me to a point I didn't write down is it's good that you bring the records in to show us, but those are not viable medical records. Those are patient education handouts.
Oh, wow.
And are not really of interest to a clinician. We get them all sent to us electronically, the real meat. So you can show it to me, but I'm not going to look at it very closely. So if they didn't do anything for you, it's because you didn't need anything done. So celebrate this, okay?
Right.
And they work with really sick people that totally might be crabby. Cut them some slack, especially since COVID. The providers that work in this community don't always live here. Sometimes they'll fly. They fly to the area. They stay in this like frat house. The one I stayed in was out by the prison, and you're not sleeping on clean sheets. The guy in the room is snoring and has bad breath, and it's not like they're here because they like being here. They're trying to perform a service. They're trying to make a living. So it's those two things, and COVID has made that a lot worse because their kind of universe science now is kind of hated, and that's unfortunate.
Go back on I think it was KFUG that did it, not Redwood Voice, but the KFUG YouTube channel, and there's the demonstration outside the hospital in which, the people working in the hospital came out, as they could and just shared their stories of just how difficult it was at that time during the pandemic to be there, to be on the front lines, to deal with all of that, to deal with the death. People were dying at this time inside the hospital. And they're not just there to piss you off.
No, they're not. They're human beings. They're crabby. And the ER doctors especially have horrible things. That you may not realize it, but maybe they lost somebody's infant baby to SIDS. So horrible things happen in their day. Be blessed that that's not happening to you, and be nice to them. So, because they really do a great service for us, and they're really great people.
It is. It's, and even when you pile on all the other things that happen, in poor communities, in rural communities, where the ER is really, and for a lot of folks, the first and last line of healthcare that they access and are capable or able to access, they do even more in those regards. At least I think draw more water in the community because they're so important.
Completely.
Yeah.
Yeah, Stutz is an ER physician, our public health officer.
That's right.
Yeah.
Yeah.
I'm a big fan of his work.
Yeah. Thank you, Lynn Szabo. Is there anything else about ERs we need to know?
No.
No, that's it. You got it all.
I got it all. I think I got it, everything I wanted to say.
Lucky you, listener. You now know everything you need to know about ERs and how best to access. And really, even more importantly, after your visit, your unexpected visit to the ER, you can look back on it and you can say, all right, well, yeah, I sat there for 3 hours and that was probably justified that I sat there that long and other people didn't. And,
Right.
it all makes sense now.
Yeah.
I would love to in the future, and we're just over time right now, so we'll sign off really quickly. I would love to get some sort of behind the scenes. You talk so much about things that are cool to you or that are interesting to you medically or even just socially, working back in the behind the scenes kind of. You're always dropping these little sayings and
Right.
we call it this and we call it that. If at some point, if we could just think about taking our listeners behind, what do we call it? The white curtain, the white, and hanging out in the break room. What a doctor.
I have a ton of stories, but not necessarily HIPAA approved.
Yeah,
I've been kind of the like innocent bystander in some wild stuff.
Okay. All
So
right.
yeah.
That might be interesting to see. Or just, I don't know. I just next time you say something like that, I'll point it out. Yeah, like that. I want to know more about that kind of.
Okay.
I want to feel like we're on the inside.
Oh, wow.
All right, Lynn Szabo, PA. That's it for this week's Health Matters. Thank you so very much, and we'll see you next week.
All righty.